Good morning, folks. Welcome to the 2024 J. Grosfeld Scholars Session. On behalf of the APSA Foundation, we are deeply grateful for your invaluable support of these early career surgeon scientists. Please see the auction tab on the meeting app. It's on the home page of the meeting app, and you'll find unique ways to give to support the future of pediatric surgery scholarly activity. Also, Dr. Fallett has worked diligently to put together a super cool virtual and in-person auction tomorrow night. All of those proceeds will support future scholarly activity through the APSA Foundation. Her daughter, Krista, also is largely responsible for a lot of the graphics and the interaction on the auction tab, et cetera. So please be thoughtful when you go through the different options of things to bid on and so forth. You don't have to be present in order to win, so those online, feel free to jump into the virtual auction as well. I also want to introduce Dr. Nicole Kuss, who's one of the research fellows at the Children's Hospital of Philadelphia, and she'll be moderating the online chat session, and she's seated here in the front row. So, our first presenter this morning will be Dr. Brian Craig from Children's Wisconsin and Medical College of Wisconsin. His research supported through this award has focused on immune phenotypes in the neuroblastoma tumor microenvironment of Ridgewood disease after surgery. So Dr. Craig, thank you.
Good morning, everybody. Dr. LaForne, thank you for hosting and for that introduction, and thank you for the opportunity to share some of the work that we're doing today. It's a long title, I acknowledge that. I would summarize it for you all by saying we're interested in the interaction of the tumor and the immune system after surgery in the disease that's not removed by surgery. And I'm going to take you through the work that we've done supported by this award to build a model around that and explain why we're interested in it. So this is a setup that everyone in this room will be very familiar with, right? We operate on metastatic neuroblastoma. We have diffuse disease, most often in the bone marrow, a really ugly-looking primary tumor, most often in the abdomen. You say, well, what's the role of surgery here? The best, most recent North American data we have is that giving a really good effort at getting near all of the disease out will decrease the local progression, but it does not seem to have an effect on the metastatic progression of disease or the overall outcome. This is COG, published COG data on the location of first relapse or progression, showing you that 4 out of 5 children will relapse or progress in the metastatic location. So to put it very simply and to frame this talk, we do a major operation for local control, even though we know there's pre-existing metastatic disease. And now I'm framing this in neuroblastoma, but everyone will also be very familiar that the similar situation arises in Wilms tumor, hepatoblastoma, a series of other solid tumors that we all operate on. So it leads us to ask the question of, how does surgery affect cancer other than its obvious tumor debulking effect? This question's been asked a few times in the past, and what we learn is that when you expose, in these situations, an animal in a preclinical model to an operation, usually just a stress operation, not an excisional operation, you will lead to tumor growing faster or relapsing sooner or having a denser metastatic outgrowth. So this is older data. This is from Dr. Fisher in the 50s in Pittsburgh. He's, of course, well known for lumpectomy and doing one of the first randomized controlled trials. At the same time, he was doing a lot of work in the lab looking at these effects of surgery on cancer, and he had this sort of culminated in this very elegant experiment that I'm not going to go through in detail, but suffice to say there was a liver metastatic model in a rat where he showed very elegantly that it's the repeated exposure to surgery and not just time that leads to a reactivation of a dormant tumor cell. Fast forward, there are two groups that have, over the last 20 or 25 years, done a lot of work, one group in Ottawa and one group in Tel Aviv, that have built some preclinical models around lung metastasis and a tail vein injection and show that a surgery added to that model, unrelated to the lungs and unrelated to the tumor injection, will increase the frequency and density of metastatic formation. There's a research group in Pittsburgh Samar Tomei, who's shown in a liver metastatic model of colon cancer that when you add an ischemia-reperfusion injury to the liver, that increases the metastatic density, and then when you inhibit neutrophil function, that actually will partially or completely reverse that effect, suggesting that there's an immune component. I should also say that the two other groups I mentioned have done a lot of nice work showing that the cell type that is probably responsible in their model for this phenotype are the natural killer cells, and they've shown that the natural killer cells are functionally inhibited by this exposure to surgery, though the molecular mechanisms remain unknown. So this is the hypothesis that the systemic response to surgery, really the patient or host response in an animal model, is what's driving this tumor growth. And we wanted to first ask, does this happen in neuroblastoma? So we took an established model of neuroblastoma that is published by the Sondel group in Madison, looking at that is a syngeneic, so the cell line that gets used is on the same genetic background as the wild type BLAC6 mice, and they've published this testing a variety of immune therapies against neuroblastoma. So we took that model, which is an intradermal tumor implantation model, and we added surgery to it, because we wanted to model this patient or host response to all the things that happen in surgery that it takes to get someone through the operation to do that tumor debulking, right? So they get exposed to anesthetic agents, opioid medications, evaporative losses, fluid shifts, capillary leak, an inflammatory response, bleeding, sometimes blood transfusions, and then some amount of tissue injury just from the manipulation and handling of tissues to remove the tumor. So we have a model that we developed where we implant the tumors in the flank, like the established model, and then we perform an abdominal operation that's non-excisional. We open the abdomen, pull out the intestines, do a controlled crush of the liver edge to simulate some parenchymal tissue injury. We time it, so they're all about 12 minutes long, and we track that data and watch the distribution of how long it's taking us to do this operation. We give them a dose of opioid, close up the abdomen, let them recover, and then they go back to their home cage. The control group gets the tumor implantation, but none of the surgery exposure. And then we follow the tumor growth over time. And what we found when we did this in a wild type BLAC6 mouse that's totally immune intact is that, as you see in the blue line, the surgery exposed animals, the tumors grow faster, about twice as fast at each time point over time. I'm showing you the early tumor growth as it's first taking off, but we also follow these out late, and I'm not showing you all that data, but they also have a shorter tumor-specific survival, meaning they hit their endpoint sooner when they're surgery exposed compared to the control animals. You'll notice that it takes about 11 to 14 days before we can detect a difference between these tumors, and this holds up in both female and male mice. So I mentioned some of the immunity, some of the data that exists in other preclinical model systems that suggest the immune system in some form may be responsible for this effect. So this is our central hypothesis for all of this work, is that this systemic response to surgery that we're able to demonstrate in this model is, we think, acting through, or hypothesize is acting through an inhibition of the anti-tumor, the intrinsic anti-tumor immunity. This could be interesting in neuroblastoma because it is a prototypical sort of cold tumor, very low antigen presentation, low tumor mutational burden, which is different from some of those other tumor types that have been tested. Before we could test this directly and ask, is the surgery effect actually doing something to the immune system to cause that tumor growth effect, we first wanted to know, is the immune system in our mouse model responding in a stereotypical way that we would expect it to respond? And so we have our wild type mice, our surgery model that I explained, and we asked what is the early immune response to surgery in our model. So we looked in two places to test this. We first looked in the circulation, and we looked at a series of cytokines. And you'll see, not surprisingly, that the IL-6, which is your classic pro-inflammatory cytokine, is way up with the surgery exposure, as well as IL-16 and other cytokines. IL-16 is a cytokine, but sort of has a damage-associated molecular pattern function, similar to like an HMGB1 or other damage molecule. And there's a series of chemokines that are all pro-inflammatory chemokines that control the recruitment and movement of immune cells that are also increased after surgery exposure. GCSF, which is a growth factor, is also increased, and you would anticipate that that would instigate a myeloid response. We then looked in the spleen to look at the cell types, and we found that immature myeloid cells are increased after surgery. And interestingly, the two major antigen-presenting cell types are actually markedly decreased after the operation, suggesting that there's a systemic immune suppression that happens with surgery. So here's our model, here's the surgery effect, increased growth, systemic immune suppression. So how do we test that direct hypothesis of the immune involvement in this effect? So we took an immune-deficient mouse that has the same genetic background, that's missing its T cells, B cells, and NK cells. We applied our surgery model, and we found that the tumor growth effect completely went away. This suggests to us that the surgery effect we see in our wild-type model is being driven, at least partially, if not completely, by the immune system. To test this a different way, we went back to the wild-type mice. We performed our surgery model. This time we used a classic innate immune activating pharmacologic agent to act as an immune booster given perioperatively around the time of the operation, and we found that giving that selectively reversed the pro-growth effect of the surgery exposure. So the surgery mice with no drug are in the dark, heavy blue line, and then adding the drug is in the heavy green line, and you can see a reversal of the effect. So what I've shared with you is that we've done a lot of work supported by this award to establish the model where now we can, in the current work that's ongoing, we can actually start to ask some of the specific mechanistic questions of what is it that's leading to this effect. I have to, of course, thank a lot of people quickly, most importantly, the APSA Foundation and everyone who supports the APSA Foundation. I think I'm a prototypical sort of beneficiary of this. As you see, that's the award directly supported foundational work that we can now dive in and do more specific mechanistic and potentially translationally relevant questions. And we've been fortunate to receive some competitive local funding, Pilot Innovation Award, and a Career Development Award. I have to thank my clinical division partners because without them, the time that it takes to do all this would not be possible. So they deserve the first thanks. Dr. Lal, Gourlay, and Evans have really worked to establish the environment to enable this success. And I have an awesome scientific partners that are intensely critical and intensely talented and really ensure that the data is rigorous and good and highly repeated. So it's good. Thank you for listening.
Thank you, Dr. Craig, and tremendous progress. We'll open up the floor, both in person and virtually, for any questions. I do have a comment to kind of tie some work conducted through Dr. Erica Newman's lab and that Kiana Williams shared on Wednesday, and that was basically a stress model that they showed progression of neuroblastoma in different contexts of stressors, such as food insecurity for the mice, and then social isolation. They showed some corticosteroid elevation data, which was fascinating. And then I think we know Sam Sofer's tremendous work on surgery-accelerated metastasis in bone sarcoma models. So what's the linchpin here? What is tying it all together? How do you speculate and say that what we do, what stressor is suppressing tumor surveillance? Thank you.
I think it's going to be an inhibition of the anti-tumor effectors in the microenvironment. I think it's going to be immune-driven, but we'll see. I think it'll be important to understand some of the deeper mechanisms of how those immune cells that have been shown in these other models and are actually inhibited, because ideally you'd like to identify some agent that can reverse that effect and sort of neutralize this unintended consequence of surgery.
Great. Dr. Farmer.
Diana Farmer, great work. Ooh, don't need to shout. So I have a question for someone who thinks deeply about this area, and particularly want to congratulate you for bringing this into the children's environment. But now that we do so many needle-guided biopsies for cancer in so many arenas, is there a role for anti-inflammatories after surgery or after biopsy to sort of mitigate? I think that maybe that's a high-risk time in the cancer journey for our patients. And just for someone like yourself who thinks about this a lot, is that crazy? Should we be thinking about it? What are your thoughts?
Certainly not crazy. Thank you for the comments and everything. The question, yes, so we partially do this. We give a lot of our patients Toradol, which is a major anti-inflammatory, and maybe having a benefit that is not the reason we're giving it, but we may already be doing this in some ways, protecting against this effect. There have been some studies, both preclinical and some clinical trials in breast cancer, colon cancer, trying to give beta blockers, trying to give high-dose NSAIDs. Those studies are interesting. They can show the expected immune changes that you would find, but of course, trying to look at overall survival or event-free survival, that's a hard endpoint to measure clinically, so those trials sort of fail, so to speak. But I think there's something there, and I think we have to think more deeply about how do we, if we're taking this into the clinic at some point in some way, or we're taking something we're already doing in the clinic with Toradol, and we're going to look at it for this reason, how are we measuring that effect? How are we defining benefit for these children? Because obviously, survival is an incredibly complicated thing. There's so much that goes into that that's not all this. So yes, is the short answer. It's very exciting. Thank you.
Dr. Cuss, anything from online? Okay. All right, great. Thank you, Dr. Craig. All right, our next speaker is Jason Robertson from the Cleveland Clinic Children's Hospital, up in Cleveland, Ohio, of course. And he will share his work exploring mitochondrial dysfunction in congenital diaphragmatic hernia. I think there was a typo in the program. It has nothing to do with neuroblastoma. It's just a different way of considering pulmonary hypertension and its lethality in nitrogen-induced models. Dr. Robertson.
Well, thank you for the opportunity to be here today to present. I have no disclosures. So, as you all know, CDH mortality is really closely linked to pulmonary hypertension and pulmonary hypoplasia. But the treatments for this disease have suffered from incomplete understanding of the pathophysiology and really attempts to translate treatments that were designed for adult-type pulmonary hypertension to CDH-associated pulmonary hypertension. So the metabolic theory of pulmonary hypertension suggests that alterations in bioenergetics lead to dysfunction of downstream processes with subsequent development of disease. And mitochondria are semi-autonomous organelles that are really best known for generating energy through the electron transport chain, but they're also components of a complex and dynamic cellular network with several layers of cell signaling and cell regulation. Endothelial cells in particular are sensitive to changes in these mitochondrial and bioenergetic cell functions because they're the first to sense low oxygen concentrations. So altered endothelial bioenergetics can affect vasoconstriction, production of reactive oxygen species, vascular growth, and vascular remodeling. Our work has the underlying hypothesis that CDH-associated lung disease is precipitated by a combination of reduced vascular growth and increased vascular remodeling. So in order to study ways that we can drive normal controlled angiogenesis while limiting abnormal endothelial cell changes, we're studying later stages of lung development, which are really the prime windows for either prenatal or postnatal interventions. We started by using the nitrophin rat model of CDH, and for this study, we used fetuses at the last stage of fetal lung development, or the saccular stage. We used single-cell RNA sequencing to study the transcriptome of individual cells in the fetal rat lung, and in endothelial cells, our bioinformatics analysis predicted upregulation of pathways specific to production of reactive oxygen species, mitochondrial dysfunction, and decreases in pathways for oxidative phosphorylation. That approach allowed us to identify several mitochondrial genes that were downregulated in CDH. Those genes affected complexes 1, 3, 4, and 5, as well as the main driver of mitochondrial fission, and a significant outer membrane transporter protein that's actually responsible for bringing all of the nuclear encoded mitochondrial genes into the mitochondria, and then subsequently regulating mitophagy as well. So based on these data, we hypothesized that we'd see dysregulated mitochondrial bioenergetics and mitochondrial dynamics in CDH, and that understanding these changes could lead to better and novel diagnostics and therapeutics. I tried several times and several approaches to isolate pulmonary endothelial cells from the nitrophin fetuses to use for additional experiments, but I was unable to isolate pure cultures there. So as a result, I changed my approach and began using a human umbilical vein primary cell culture model, which I actually think is more translational. So umbilical cords are fetal tissue. And since CDH lung tissue is not readily available for study, these cells are a model to use to study patient-specific endothelial changes in human CDH. And while they most directly reflect systemic changes in CDH, our findings and data to date suggest that they may actually approximate the pulmonary vasculature as well. So we currently have 5 female and 6 male CDH specimens and a total of 19 controls. And you can see the clinical data breaking down the clinical characteristics for those patients in the table on the right there. We did single-cell transcriptomic analysis of those cells as well, and in human CDH endothelial cells, we saw an angiogenic and proliferative phenotype that was also marked by upregulation of cell inflammatory and apoptotic pathways, which I didn't represent in this figure. But taken together, those could all negatively impact pulmonary vascular remodeling. We performed angiogenic tube formation assays to look at angiogenesis and confirm a functional phenotype to correlate with our transcriptomic data. And while this particular work is ongoing and early, it seems that CDH endothelial cells are more quick to form angiogenic networks, and they also displayed faster migration into sheets of endothelial cells, and then subsequent faster apoptosis. That's all consistent with our transcriptomic data, and we're in the process of performing several confirmatory assays. So with those functional changes in mind, we began to study mitochondrial function in these human CDH endothelial cells as a potential mechanism underlying these changes. So using the Seahorse analyzer, we can study different components of mitochondrial respiration. The assay measures oxygen consumption rate, or OCAR, both at basal levels and then after sequential administration of various drugs that affect different components of the electron transport chain. So looking at these curves of mitochondrial respiration broken down by sex, we start to see clear differences. And the oxygen consumption is higher in CDH mitochondria. That's a change that's particularly pronounced in females. And it's higher in males compared to females. When you look at these data separated by clinical severity, we again can see clear differences in sicker CDH patients. So the oxygen consumption is greater in those with longer hospital lengths of stay and in those with smaller lungs as predicted by prenatal MRI. Here you can see that the basal OCAR and basal metabolism, which excludes any non-mitochondrial respiration, are higher in CDH. The differences are statistically significant in combined CDH comparisons and in females across the board. And there are trends that are clearly present in and approaching significance for male basal respiration and comparisons based on hospital length of stay. You can also see that male mitochondria are consuming more oxygen than females. These graphs now show that when cellular respiration is at maximal capacity, which is facilitated by maximal utilization of resources, that is sugars, fatty acids, and proteins, CDH cells consume far more oxygen and have a greater reserve with which to respond to stress. And looking closer, CDH endothelial cells also have significantly elevated levels of non-mitochondrial respiration, which is generation of reactive oxygen species. So this is true in all CDH cells in both sexes, but the levels of reactive oxygen species are highest in male CDH endothelial cells. This finding is consistent with what has been shown in lungs from animal models of CDH, and it has potential to impact cell signaling, mitochondrial dysfunction, and apoptosis. Now, typically, electron transfer and ATP synthesis are indirectly coupled by a transmembrane electrochemical proton gradient. And in CDH, we actually found increased proton leak through the mitochondrial membrane that is not coupled to ATP production. And so this effectively reduces the efficiency of ATP generation. And again, it's more pronounced in males than females. Now, this graph shows how the ATP-linked OCAR correlates with the basal OCAR in CDH and control patients. And in general, the CDH patients are consuming far more oxygen to produce ATP. Now, this doesn't mean that they're making more ATP, and we're currently investigating reasons that could explain this, but it may be that they're having issues with mitochondrial membrane potential, as in the mitochondria are just sicker, that there are differences in mitochondrial number, that it's related to high mitochondrial reactive oxygen species production, differences in the complexes in the electron transport chain, or some combination of these. We also studied levels of glycolysis by looking at the extracellular acidification rate, which measures lactic acid levels that are formed during conversion of glucose to lactate to provide a measure of glycolytic function in the cell. And there's a lot of variability given our small sample size, but males with CDH trend towards having higher glycolytic function than females with CDH or controls. Likewise, CDH endothelial cells from patients with more severe disease have trends towards higher glycolytic activity. And this shift towards higher glycolysis suggests that increased oxygen consumption you see in CDH endothelial cells is not going towards ATP production, and so the cells are shifting more towards aerobic respiration to compensate for that. I also wanted to understand better whether the increased maximal respiration achievable in CDH endothelial cells is related to a shift in fuel source utilization. And to test this, we performed what's called a substrate impact assay, wherein you do a mitostress assay following incubation of the cells with glucose, fatty acids, or glutamine. And we found that the spare capacity in control cells was most impacted by blocking glutamine. But there were also significant effects seen when we blocked other substrates like fatty acids and to a lesser extent glucose. And when we did the same in CDH cells, the impact of that substrate blockade was much less. And our data suggest increased importance of glutamine metabolism relative to other blocked fuel sources, and also potential use of new fuel sources that we didn't block. Again, when you compare males and females here, it's worth noting that the differences are most significant in females. So in conclusion, patient-specific umbilical vein endothelial cells are a model of CDH endothelium that's characterized by increased inflammation, oxidative stress, changes in basal endothelial cell functions, and unique metabolism. Second, CDH endothelium consumes more oxygen to generate ATP, due in part to reduced ATP coupling efficiency and increased reactive oxygen species. We see that CDH endothelium also shows evidence of altered fuel source use, which has implications for disease pathophysiology. And we see differences in metabolism that exist between sexes. So I'd like to thank the APSA Foundation for this opportunity. Certainly the data I've generated the last year has opened up a lot of new avenues of investigation and is going to be applied to a number of grants I have upcoming in the next few months. I'd also like to acknowledge my mentors and collaborators, my lab tech, and several others who've helped me with various components of this project along the way. And I'd be happy to take any questions.
Thank you, Dr. Robertson, and congratulations on this tremendously sophisticated work. Dr. Dunn?
James Dunn, Stanford University. Very interesting work. It's especially fascinating to see that the culture cells retain the phenotype that's different from the controls. How long does that last in cell passages? And if it continues to retain that phenotype, do you think it's because of some genetic or epigenetic changes in these cells that are different from the controls?
It certainly could be. I mean, all the cells that we used for these experiments were about passage 5 or 6. So it was relatively late in passage. Doesn't seem to be lost. And that could support it being mitochondrial changes that are underlying some of these abnormalities.
Thank you.
Dr. Wang?
Casper Wong from Toronto. I wanted to congratulate you on your work. This is really, really novel in its perspective in terms of the pulmonary hypertension issue that we deal with the CDH patients. I had two questions. One was similar to what James asked, but was more upfront, because obviously early on you culture these cells and you see a difference. And while they are not exactly the cell population that you want to, they're the best surrogate that you have in a human real-life, real-time model. And my question is, there's already a difference. You start culturing them, there's already a difference. How much of that is a reflection of the environment that these endothelial cells from the umbilical vein were exposed to before these babies were born, right? Because they've been active and present, and how much of that might actually reflect epigenetic changes that might have already occurred in those cells prior to delivery. So that was my first question. And the second question is, obviously, whenever you culture cells, and as I understand, not being somebody that cultures endothelial cells, my understanding is nonetheless that it's challenging to culture and get primary culture cells to survive. How much of this is reflective of the culture media? Did you have to change the culture media to be able to observe the differences that you see? Are there things that you had to include or exclude in order to be able to do this? And then my third question is, you might be seeing some changes, male versus female. Would that reflect potentially the inheritance patterns for mitochondrial DNA that are different than normal DNA?
Yeah,
So,
no,
anyway,
all great
thank you.
questions. So regarding the cell culture, it's very difficult to get primary cells, like you mentioned, from lung tissue. But one of the nice things about this HUVEC model is that it's actually very easy to collect HUVEC cells and to get them to grow. And so we didn't have to make any changes to the media. We just used kind of a basal endothelial growth media with various growth factor supplements that's commercially available. And they grow very well in that. When we did the angiogenesis assays, we used starvation media so that they really had to kind of produce their own growth factors. And we still see changes with no stimulation added. The changes were more pronounced when we did stimulate with VEGF, so that's what I included in this talk. With respect to the question about inheritance of mitochondria and all, that's absolutely a possibility. There's a lot of changes that you see in the inflammatory milieu in the umbilical cord and really just systemic in CDH patients. There's some data by Dr. McKenzie from a number of years ago that actually looked at inflammatory mediators in the umbilical cord, and several that she saw elevated were also elevated in our transcriptomic data. So that's one influence, but like you said, you take that away and you still see these changes. So there's been some change, whether it's to mitochondria or some sort of other epigenetic or genetic change that we still need to tease out. I can't remember what your first question was, I'm sorry. Oh, sorry,
That's good.
Being
Thank
told
you.
we're over time.
Yes. Thank you, Dr. Robertson, and congratulations on this progress. Okay, our final speaker is Nicole Wilson from the Golisano Children's Hospital at the University of Rochester, and she will share with us her study evaluating photodynamic therapy for perforated appendicitis, so taking a very different and novel approach to something very common. Dr. Wilson, the podium is yours.
Thank you so much. I have no disclosures. So the vast majority of this audience knows the scope of this problem, and I'm not going to belabor the point, but to suffice it to say that appendicitis is the most common general surgical condition affecting children, and it contributes to more morbidity and healthcare resource utilization than any other pediatric general surgical condition. About a third of the cases in the US present with complicated appendicitis, and these cases, this subpopulation suffers the majority of the morbidity associated with acute appendicitis. In our institutional population with complicated appendicitis, 13% required drain placement after appendectomy for presumed abscess, 11% returned to the ED within 30 days, and 34.5% underwent some form of postoperative imaging. Our mean length of stay for complicated appendicitis was 6.48 days, but we can all remember the kids that stayed much longer than that, the kids that looked like a bomb went off in their abdomen at the time of appendectomy. We've been treating complicated appendicitis using the same techniques for a long time, with surgery and antibiotic therapy the mainstays of treatment. Research has tweaked the duration of antibiotics that these kids get, but there have been no new therapies for complicated appendicitis in decades. The addition of photodynamic therapy potentially offers a new, innovative treatment for this common problem. With proof that this technique works, we can hope to decrease deep space infections and hopefully reduce hospital stays. So our objective was to demonstrate proof of concept for antimicrobial photodynamic therapy as a treatment for intra-abdominal infection and complicated appendicitis using a rabbit model, and then to demonstrate efficacy against bacteria isolated from human samples. We hypothesized that photodynamic therapy will significantly reduce bacterial burden both in vivo in the rabbit model and in vitro. PDT, or photodynamic therapy, uses a combination of laser light and a photosensitizer to generate reactive oxygen species. In our case, we're using methylene blue as our photosensitizer. The methylene blue is taken up preferentially by bacteria, and the addition of laser light excites the methylene blue, which in the presence of tissue oxygen generates reactive oxygen species. Essentially, the bacteria take up the methylene blue, laser light generates reactive oxygen species within the cell membranes, which then damages the membrane and kills the bacteria. We chose methylene blue as our photosensitizer because it's safe, inexpensive, and FDA approved to treat methemoglobinemia. We're just repurposing it as a photosensitizer here. PDT is bactericidal against a wide variety of microbial species, including those resistant to antibiotics. And unlike antibiotics, PDT does not result in acquired resistance. Clinical success for PDT has been demonstrated in endodontic infections, onychomycosis, chromoblastomycosis, and very recently, intra-abdominal abscesses. The combination of methylene blue and PDT has also been used to treat antibiotic-resistant biofilms on endotracheal tubes and caseous lymphadenitis in sheep. This is an outline of our methods for the first aim, in vitro PDT on human samples. We already collect fluid for culture from every patient with perforated appendicitis at our institution. The fluid is sent to clinical microbiology for culture and speciation. And for this experiment, after clinical microbiology cultured and speciated the bacteria, we obtained the cultures and tested them in vitro with methylene blue and PDT. The middle 96-well plate shows our typical setup in vitro, with the top 4 rows getting laser light therapy, with no methylene blue in the first 2 rows and methylene blue in the second 2 rows. The bottom 4 rows got no laser light therapy with the same setup for methylene blue. This setup will carry through the following slides as I go through our preliminary results. Our outcome for this experiment was log base 10 reductions in colony-forming units, as illustrated with the 96-well plate on the right. So we obtained fluid samples from 30 subjects. Bacteria were isolated from 93.3% of specimens, and 86.7% of them were polymicrobial. The most common organisms in order were E. coli, Strep anginosus, Bacteroides fragilis, Pseudomonas aeruginosa, Bacteroides ovatus, Actinomyces, and then a myriad of other species. So after speciation and culture, we then plated and grew the bacteria and subjected them to methylene blue PDT and control conditions. And this graph shows our results for E. coli. It's set up in the same way, and all of the subsequent graphs will be as well. Without methylene blue on the top, laser light in the first 2, methylene blue here, and then no laser light on the bottom 2 without methylene blue and methylene blue. For E. coli, we saw that the addition of methylene blue alone, even without laser light, significantly reduced bacterial levels, while the use of laser light alone did not. However, when methylene blue was combined with laser light, the bacterial reduction was significant, resulting in a 5.9 log reduction overall in E. coli levels. We performed the same set of experiments with Pseudomonas aeruginosa and found the same results. Again, methylene blue alone without laser light kills the bacteria, but only some. The use of laser light alone does not. And then the combination of methylene blue plus PDT is significantly effective and resulted in a 2.9 log reduction overall in Pseudomonas levels. Finally, in this past year, we've repeated the experiments with strep anginosus, and we saw a difference with the addition of methylene blue alone, but that was not statistically significant. Laser light alone was not significant, and then again, the use of methylene blue PDT resulted in a 5.8 log reduction in overall bacterial levels. We're currently working on completing the rest of the testing with the additional bacterial species cultured. Next, I want to show you the progress we've made on AIM-2. This experiment consists of 3 surgeries performed over 4 days. On day 1, we create our model of perforated appendicitis by taking down the mesoappendix, ligating the base of the rabbit appendix, and creating a cautery burn to ensure that it will perforate. The rabbit is then recovered and allowed to eat and live normally for 40 hours. On surgery day 2, we gain laparoscopic access and collect a fluid sample. We then remove the rabbit appendix in the standard fashion using endoloops, and then laparoscopically we fill the abdomen with methylene blue and allow that to incubate for 10 minutes. The methylene blue is then washed out and the abdomen is refilled with saline and intralipid. An optical fiber is introduced through one of the laparoscopic trocars and submerged in the solution. Laser light is then applied to the abdominal cavity for 20 minutes, and the intralipid is then rinsed out and the rabbit's allowed to recover. Finally, on day 3, the rabbit is euthanized and we again gain laparoscopic access and collect a fluid sample for post-BDT bacterial counts. We then dissect the rabbit to obtain samples of all the major abdominal organs for H&E stain and subsequent immunohistochemistry to hopefully demonstrate that there are no off-target effects of either the methylene blue or the laser light. So let me show you a video of how this experiment progresses. On day 1, we ligate the rabbit appendix and create our model of perforated appendicitis. By surgery day 2, which is 40 hours later, we can see clear evidence of perforated appendicitis. At this time, we collect a fluid sample and perform an appendectomy. After appendectomy, we instill methylene blue in the abdomen and allow it to dwell for 10 minutes. These are some pictures of the abdomen after methylene blue has been rinsed out. We then instill a dilute solution of intralipid into the abdomen to act as a light scatterer for the laser light. With the abdomen full of dilute intralipid solution, an optical fiber is introduced and the laser is activated. The laser light is applied to the abdomen for 20 minutes. This is a video of the abdomen after all of these steps on day 2. And then on day 3, we again take a fluid sample. This is a control animal that got methylene blue but no laser light therapy. And this is an animal that received methylene blue plus PDT, and you can see some slight differences here. So for our preliminary results for AIM-2, we've performed this experiment in 6 rabbits. We've been able to reliably initiate our model of perforated appendicitis, including clinical evidence of peritonitis and establishing a polymicrobial infection. Furthermore, we have successfully deployed methylene blue PDT in a laparoscopic setting in a rabbit, which is actually pretty tough to do. The graph on the right shows some initial numbers for our pre and post PDT bacterial counts. The top 2 show gross colony counts from control animals who got methylene blue but no laser light. And the bottom 2 rows show a modest bacterial reduction, or at least bacterial stasis, for our single animal that's gotten methylene blue plus laser light treatment. So in conclusion, methylene blue PDT effectively kills bacteria from human subjects with perforated appendicitis in vitro. We found that the magnitude of bacterial kill depends on the specific species and a little bit on the colony even within the species. We've successfully been able to create a rabbit model of perforated appendicitis and laparoscopically deployed methylene blue PDT in this rabbit model. Our preliminary results for this AIM are encouraging. However, there's still work to do. We need to continue our in vivo bacterial quantification and speciation, and we have additional species to treat with methylene blue and PDT in vitro, and those experiments are ongoing. For AIM-2, our goal is to complete 20 rabbits, 10 controls, and 10 PDT. And finally, concomitant with this work, we've been working on developing a novel laparoscopic instrument that will allow us to deliver the methylene blue and the laser light therapy at the same time. I'd like to thank the other members of my lab, along with my collaborators, Tim Barron in the Barron Lab and Marty Pavelka in the Pavelka Lab for their essential work on this project. Finally, I'd like to thank APSA and the APSA Foundation for their support through this Grosfeld Award, without which this work would not have been possible. Thank you very much.
That's a crazy cool model, Dr. Wilson. Congratulations.
Thank you.
Dr. Malik.
Yeah, Dr. Wilson, congratulations. That is incredible work. Establishing the model alone is very impressive. The outside of the box thinking is welcome and really exciting. I did want to ask a question. PDT has been used in some other parts of medicine, as you mentioned, including in cancer. There are clinical trials for head and neck cancers using IR700 as your photosensitizer. Some of those studies did show unfortunate side effects on surrounding tissues, including vessel rupture and things like that. I'm not sure if you see that at all with methylene blue. Is that something you're planning to look into? Thanks a lot.
Thanks for your question. So we do collect the rabbit tissues of all of the major abdominal organs afterwards and have not seen any off-target effects thus far. One of the reasons we chose methylene blue as our photosensitizer in this application is that it allows us to use a lower fluence rate in the laser and therefore hopefully avoid those off-target effects. And one of the things that we're going to do in the future is, I know everybody's cringing at an extra 30 minutes of operative time if this were to roll out, but we think we can dose adjust essentially the laser light and get that time down.
Time for 2 quick questions. I can't see because I'm blinded by the lights, but middle mic. Go ahead, you. Yeah.
Oh, yes, thanks. Sung Kim from UCSF. There are probably white blood cells inside the abdomen fighting the bacteria. Do you think this method would also affect or kill the white blood cells?
That's a fantastic question and not something that we've looked at, but definitely something we could test for with our fluid samples. So I'll do that.
And to close the questioning, Dr. Besner.
Thank you for a really thought-provoking presentation. It was so beautifully delivered. My question was about the delivery time. It's great that you're going to try to administer the methylene blue and the laser light at the same time now. You had mentioned that this has been used clinically in abscesses. How short a period of laser light have they been able to use effectively? Thanks again.
Yeah, so there's a phase 1 trial in abscesses, which it's a slightly different beast because it's a well-formed abscess cavity, and you're not trying to distribute the laser light throughout the entire abdomen. And that's really the kind of trick of this for our experiments. The abscess time, they're using the laser light for 10 minutes. And the dwell time for the methylene blue is 5, so it's 15 total in terms of extra time. And they interesting deliver it. It was done with an IR model, and they deliver it through like a pigtail drain. So there's definitely room to move in there. But since we're trying to make sure that we can get the light to all of the abdomen, we started with this fluence rate.
Okay, thank you, Dr. Wilson. That's
Thanks.
terrific. And thank you to all the Grosfeld scholars for this fascinating session. And super important congratulations to everybody supporting the Grosfeld Scholars mission. It really is hugely beneficial to our young scholars and the future of academic pediatric surgery.